Good afternoon, Rotarians and guests. My name is Reg Smith and I'm your MC for today's meeting of Rotary Melbourne. Today, once again, we're broadcasting from various locations. And if you have any difficulties in your participation in the meeting, just be assured we will be recording and loading today's meeting as a podcast and video presentation on our club website in the next day or so. Please note that I've muted pretty well everyone's microphones except for those who will be participating in the presenting of the meeting. At this stage, I hope you've charged your glasses and an appropriate vessel. Thanks today will be given by Barbara Urondes, after which the loyal toast will be presented by President Kevin Sheehan. Barbara.
Thank you, Reg. We are all doing very well meeting in these change times. And Professor Hugh Taylor's presentation today will remind us of this very important project Melbourne Rotary first began in discussions some 5 years ago. The Trachoma project sought to improve the health and eyesight of our First Nations people, and it has done more. It has brought Australian Rotarians together for a common cause, to end trachoma. So today I would like us to reflect on how our Indigenous communities are coping in these somewhat strange and dangerous times. And as we reflect, can we please also acknowledge the traditional custodians of the land on which we meet and pay our respects to the elders, both past and present, and extend that respect to all Indigenous Australians. And I would like to welcome you all and acknowledge our Rotary family in honour of service and fellowship. Thank you, Kevin.
Thank you, Barbara. And Rotarians and guests, I give you a toast to Australia and Rotary International. Australia and Rotary International. It's my great pleasure to welcome you to our 39th meeting of the Rotary year, our 4,039th meeting of our club and our 7th online meeting in the 99-year history, our first online Angus Mitchell Oration. The Angus Mitchell Oration is the most significant day in our calendar, and I'm delighted that we have our honorary member, Professor Hugh Taylor AC, Harold Mitchell, Professor of Indigenous Eye Health at the University of Melbourne, to deliver our 50th Angus Mitchell Oration. Hugh will be more formally introduced later in the program, but for now, welcome. Online today for this special presentation, we have our past president, Mev Connell, who you'll hear more about in a moment, as we are delighted to formally elevate him to honorary life membership of Rotary Melbourne. We have many visitors and guests joining us today. Amongst them are our past orators, and we have our District Governor, Grant Hocking, and Philip Archer. Past orators include Peter Doherty, John Bertram, and we're delighted to have them with us. I also extend a warm welcome to all visiting Rotarians and guests who have joined us today. And by the sound of Reg's count and Joe's count, as you've all joined in, we have a very large complement. There are a couple of items just to cover before the formalities, and I certainly am very proud to reflect on the 99th anniversary meeting last week, which was a star-studded event with our first online induction of a member, Chris Karotis, a celebratory video edited by Hugh Bucknell, an anniversary greeting from the Lord Mayor, Sally Capp, in her ceremonial robes, no doubt, and an Anzac commemoration by Major General Jim Barry AM, MBE, and an insightful and inspirational guest speaker address by John Bertram AO. It made it all for a very memorable occasion. Unable to join us last week online was a stalwart member whose induction date happens to always coincide with our anniversary, and he is past President David Jones, now celebrating 49 years of membership. So David, With your 50th being the same day as Rotary Melbourne's 100th, we look forward to a double celebration. Our evening meeting will be now our highlight meeting for next week. So we won't be meeting at 1 o'clock, we'll be meeting at 6 p.m. And our team, our evening meeting team, have put a great program together, which includes guest speakers, Professor John Wilson, AM, the Alfred Health, and Dr. Louise Segan, physician and cardiology trainee at the Alfred Hospital. And their topic of discussion will be, let's chat about women in medicine, hard. The Zoom details will be forwarded in the bulletin next week. And as a final reminder, our Fighting Fund, which continues to grow, enables us all to join a virtual lunch fundraising. You can have fun by selecting your menu, go to try booking with the details in our bulletin. It is now my great pleasure to call upon our distinguished member, Mev Connell, and confer honorary life membership. Mev, born in Kilcardy, Scotland in 1936 and educated in Scotland, England, was conscripted to the British Army and first served with the Gordon Highlanders as a volunteer with the Parachute Regiment, where he saw active service in Cyprus, Middle East, including the Suez invasion. After demobilisation, Mev completed his tertiary education, graduating with a bachelor's degree in science, botany and zoology. Mev met and married Brenda, while working in the north of England, and they have two daughters, Marag, who lives and works in France, and Rowena, who is the mother of their 3 grandchildren. He moved his family to Australia in 1967 after being recruited by the Australian Wheat Board, being responsible at national level for grain storage and commodity hygiene, and subsequently became the Deputy General Manager. In 1984, Mev was appointed Chief Executive Officer of the Grain Elevators Board and the Director of the Australian Wheat Board. And I do note that Mev's career has a common thread with the career of Sir Angus Mitchell, for they were both involved with grain. Mev retired from full-time employment in 1995 and provided specialist consulting services in Australia, Asia and the Middle East. And as a fellow of the Australian Grains Institute, was awarded a Gold Service Medal in the same year, and was also awarded Commonwealth Honour with the Public Service Medal. Since his induction into our club in 1987, Mev served our Rotary Melbourne in many capacities, including as a director, group captain, and ultimately as our 89th president in 2005-2006. At district level, Mev served community service chair in 2007-2009 and responded to the huge need as chairman of our district bushfire committee, which was established to coordinate the recovery effort after the Black Saturday bushfires in February of 2009. Mev also coordinated our district's response to the 2013 Tasmanian bushfires, and that year, District 9800 named Mev a Paul Harris Fellow of Multiple Sapphire. And most recently, Mev has provided valuable service to our district's 2020 Bushfire Response Committee, dealing with the aftermath of this year's other tragedy. Mev was awarded Rotary's highest individual honour in 2009, the Service Above Self Award, awarded to a Rotarian who's demonstrated exemplary humanitarian service and an emphasis on personal volunteer efforts and active involvement in helping others through Rotary. At club level, he has instigated the 4th Bridge Award, which is currently conferred annually to the leader of a team whose project or activity is judged to be the most outstanding contribution in that year. At club level, we've always been graced by the presence and contribution of his wife, Brenda, who we cherish dearly. there is no doubt that Mev's ongoing commitment to Rotary and the community at large makes him a very worthy recipient of honorary life membership of Rotary Melbourne. Congratulations, Mev Connell.
Well, thank you very much indeed, President Kevin. Good wishes to you and to our Rotary friends and all others who are present at this meeting. It's with much pleasure that I acknowledge the gift of honorary membership of our great club. It is an honor that I never envisaged that it would be appropriate for me. I was inducted into the club, as you say, in 1987 and really didn't get into gear until I retired from full-time employment in 1995 because I spent so much time overseas and interstate. After then, I certainly did put in a few quick laps, both in the club's administration and at the district level. I even had the temerity to write a paper for the board about 10 years ago that attempted to provide guidance on rules for conferral of honorary membership. I'm not sure now that I would qualify on the basis of the criteria that I recommended then. I was honored to be appointed president of the club in 2005-06, and I was particularly honored when I was selected as chairman of the Unified Rotary Districts of Victoria and Tasmania Bushfire Recovery Committee after Black Saturday, a task which kept me very busy both physically and with administration for nearly 8 years. I've always been very much impressed and have highly valued the work done by Rotary International and particularly by our own club. However, in recent years, my active involvement has seriously waned for various reasons. At 84 years of age, I have taken the view that my active capability has virtually come to an end. As observed in the writings of Robert Burns with his 1790 poem Tam O'Shanter, and by many others, time and tide wait for no man. I thank the club for the great experience I've had as an active Rotarian, and now for ongoing association through honorary membership. This is indeed a great honor. As with all honorary members, I will of course stand ready to assist the board should that be deemed appropriate or worthwhile at any time. In conclusion, I wish the club well with its ever-evolving, wonderful endeavours as a leader in the application of Rotary values. Thank you very much indeed.
Thank you, Mev. We're delighted to have you on our meeting today and to be able to confer that honour on you.
Yeah.
Today, it's my pleasure to introduce the Angus Mitchell Oration. And we commemorate Sir Angus, who was a past president of the club and the first Australian to become world president of Rotary International. Much has been written about the life and times of Angus Mitchell, and with the most recent references contained in past President Owen Parnaby's 2002 book on the history of Rotary Melbourne. Angus Sinclair Mitchell was born in Shanghai in China and moved to Australia with his father at a young age and settled in Williamstown. He became a wheat trader and was president of our club in 1931-32 and enjoyed so much that he retired at the early age of 51 and devoted the rest of his career to Rotary. He was elected district governor twice and is a great leader of Rotary during the reconstruction which followed World War II. The Angus Mitchell Oration was initiated by our Board of Directors in 1971 to honour Sir Angus as part of our club's 50th birthday celebrations. Paul Harris, who in February 1905 founded Rotary in Chicago, became a close personal friend of Angus Mitchell, and to date the oration has been delivered by 49 eminent Australians, some of which are with us today. It is my privilege today to introduce our esteemed honorary member, Professor Hugh Taylor, AC, our 50th Angus Mitchell orator. Hugh is a Melbourne Laureate Professor and the Harold Mitchell Chair of Indigenous Eye Health at the University of Melbourne. From 1990 to 2007, he was the Professor of Ophthalmology at the University of Melbourne and the founding director of the Centre for Eye Research Australia. Prior to that, he was Professor of Ophthalmology at the Johns Hopkins University in Baltimore, with joint appointments in epidemiology and international health. He's been President of the International Council of Ophthalmology and Vice President of the International Advisory for the Prevention of Blindness and Chairman of Vision 2020 Australia. He has served a number of international bodies, including the World Health Organization. Hugh is currently working close with the gap to close the gap for vision by eliminating trachoma and providing equity in eye health for Indigenous Australians. He's written 30 books and reports and more than 700 scientific papers. He has received multiple international awards and prizes, and in 2001 was made a Companion of the Order of Australia. It is now my distinct privilege to call on Professor Hugh Taylor AC, our distinguished honorary member, to deliver the 50th Angus Mitchell Oration, How to Fix a Leaky Pipe, Providing Quality in Eye Health. Thank you, Hugh.
Thank you very much, President Kevin, Rotarians, ladies and gentlemen. I do want to start off by acknowledging that although we are dispersed, we are all meeting on Aboriginal traditional land, and to pay my respects to the elders past, present and emerging, and to recognise that sovereignty of this land has never been ceded. I also want to say how honoured I am to be asked to give this oration named after Sir Angus Mitchell. It really is a great privilege. As President Kevin has said, and you know better than I do, Angus Mitchell was the previous president of the club, not once, but twice, and he was the first Australian to be president of Rotary International. It is a distinct honour to be giving the 50th oration. And as I look at the list of previous orators, many of them are well known, some of them I have known personally, but all have been extraordinary leaders in their respective fields. And it's very humbling to be asked to follow them. I have had the pleasure of reading the biography written by Owen Parnaby, Angus Mitchell, Rotarian and Peacemaker. And as I started to read the biography and also the history that Parnaby wrote on Melbourne Rotary, I started to feel an affinity for Angus Mitchell. My childhood was spent in his neighbourhood, about halfway between his two homes in Armidale and Malvern. We both went to Scotch College. Our daughters went to Lauriston, as did my sisters. I was a Boy Scout and he did so much for the Scouts. And we were both members of the Toorak Presbyterian Church. However, unlike him, I've never been an office holder in Rotary, although I am very proud to be an honorary member of the Rotary Club of Melbourne. But like him, I'm also the proud recipient of a Paul Harris Award. It was presented to me by the Rotary Club of Houston, Texas. As I read about the close linkages Angus Mitchell had with Japan, it reminded me greatly of my grandfather, who also had many close relationships with Japan, both before and after the Second World War. And as a young boy, I heard a lot about these still very unusual visits. Having completed my schooling, I studied medicine at the University of Melbourne and then trained in ophthalmology at the Royal Victorian Eye and Ear Hospital. In 1976, I spent a year working as the Assistant Director of the National Trachoma and Eye Health Program. This was an Australian-wide program led by Fred Hollows that assisted and provided eye care to Aboriginal and Torres Strait Islander people across the country. One of the things I found then was that healthy Aboriginal people have much better vision than previously thought possible. When we measure vision, we describe normal vision as being 6-6 vision. This means that a person can read at 6 metres the letter the so-called normal person can read at 6 metres. If you are very old-fashioned or an American, that would be 20/20 when the test is being done at 20 feet instead of at 6 metres. To drive a car legally, you need to have at least 6/12 vision. That means at 6 metres, you can read the letters that the normal person should be able to see at 12 metres. Well, I found that the average vision of healthy Aboriginal adults was 6/2.5. That meant they could read all the way at 6 metres what the normal person could only read at 2.5 metres. What was even more extraordinary was that there were some who had much finer vision. They could see 6/1.5. That is, they could go back to 6 metres to see the letters that the normal person would have to only be 1.5 metres away from. These findings got somewhat lost in the scientific literature, and my attempt to have them listed in the Guinness Book of Records was rejected. But then some astronomers from Sydney were studying the constellations described by the Aboriginal people a century or so ago. They could not make sense of them. There were stars that were missing. They couldn't fill in the gaps. Having talked to me about the vision of Aboriginal people, they went back with their binoculars. Suddenly, they could fill in all the missing stars that the Aboriginal people could see clearly on their own. However, the major and sobering finding of this early work on the National Trachoma and Eye Health Program was that the rate of blindness in Indigenous Australians was 10 times higher than in non-Indigenous Australians, and that blinding trachoma was still all too common. After that, a number of programs and initiatives were started. Some had some impact, but there were no major or long-lasting changes. Having completed this field work, I then went to the Wilmer Institute at Johns Hopkins in Baltimore for a year's fellowship in corneal surgery, although I ended up staying for 14 years. When I left, as President Kevin mentioned, I was a professor in ophthalmology, but also in epidemiology and in international health. I returned to Melbourne in 1990 as the Professor of Ophthalmology at the University of Melbourne, to the chair established and named after my grandfather. And later, I established the Centre for Eye Research Australia. In 1996, I was asked to prepare a report for the Australian government on the eye care needs of Indigenous Australians. I was shocked and disappointed to see how little had changed over the previous 20 years. The report made a number of recommendations. They were all adopted in principle by the government, but unfortunately, they were only partially implemented, and as a result, not much changed. So, in 2008, I took a more concerted approach to try to improve eye care. I moved to the Melbourne School of Population and Global Health and focused full time on changing the system to get equity in eye care. We have a small group who've worked very hard and done great work, and we started off with a national survey to clarify the distribution and causes of vision loss. We found the rate of blindness was now 6 times higher than that in other Australians, with cataract, diabetic retinopathy, undercorrected refractive error, and trachoma being the major causes of vision loss. And trachoma was still a major problem, particularly in the outback areas. Overall, some 84% of the vision loss was preventable or treatable, but only about 1/3 of the adults had ever had an eye exam. Amazingly, the unmet need was similar in the towns and cities as it was in the more remote areas. I often say we found the unmet need in Fitzroy to be the same as it was in Fitzroy Crossing. In Fitzroy Crossing and other remote areas, we clearly need more services, more optometry, more ophthalmology and other services. But the Victorian Aboriginal Health Service in Nicholson Street is less than a mile from the Royal Victorian Eye and Ear Hospital. the largest eye hospital in the Southern Hemisphere. All we need to do is get people to walk across Victoria Parade. Remember, 3/4 of the Aboriginal and Torres Strait Islander people live in the towns and the cities. Only 1/4 live in the more remote areas. Then we undertook a series of health services studies. We looked top down at the use of government-funded eye services. We looked bottom up with case studies of existing services. We conducted a series of focus groups within the communities and workshops with various stakeholders. We undertook a historical review of health programs over the previous 30 years, looking for the keys of success of new programs. We also undertook an economic analysis of the costs and benefits of intervening. We came up with the notion that the pathway of care or the patient journey was like a leaky pipe. There were lots of leaks or cracks where people would fall out of the broken system. If you only fixed 1 or 2 leaks, the pipe would still be leaking. You actually had to fix them all. We ended up with 42 things that had to be addressed. These formed our roadmap to close the gap for vision. The roadmap is a long-term plan to provide well-coordinated care and support for eye care. It calls for regional eye health services that are adequately resourced and supported so that they can meet their population-based needs for eye care, not just the perceived demand. They can provide appropriate case management for patients that prefer and monitor their progress. There is still more work to do, but now we have 57 regional networks in the 63 self-defined regions across the country. To help establish these regional groups, state-level eye care committees were established, and these also assist with the state-provided services, such as providing subsidised spectacles and access to public cataract surgery. We needed to get some new Medicare item numbers for eye care provided in the primary health clinics. These included an item for screening eye photography for people with diabetes. And the government has now provided retinal cameras to over 150 Aboriginal medical services to facilitate this. To raise awareness of the need for eye exams, particularly for those with diabetes, a wide range of health promotional materials and activities were developed after extensive Indigenous community input and consultation. These resources have included flip charts, videos, T-shirts, sports carnivals, and clinic reminders. The examination and referral rates for diabetic eye disease have more than doubled in this time. The government funds visiting outreach services, the Visiting Optometry Service, or VOS for optometrists, and the Rural Outreach Health Fund, or ROF, for ophthalmologists and other medical practitioners. These outreach services provided have increased, and the number of eye exams have also increased now 3-fold. However, we still need a further 25% increase to fully meet the population-based needs. Similarly, cataract surgery rates have also more than doubled, although there's still some more work to do there. So far, I've been talking about general eye care. And I know you all have, at Melbourne Rotary, a special interest in trachoma. And we are very aware and grateful for the leadership of Melbourne Rotary in introducing and convincing Australian Rotary to commit to the elimination of blinding trachoma by 2020 as a Rotarian R100 centenary project. Melbourne Rotary has done a great job with the building of these interactive water trailers led by Peter Rogers and his team, and also Rob McGurk and his team who've done a magnificent job with the End Trachoma program. We're very grateful for that. Let me talk a little bit about trachoma. Australia is the only developed country to still have trachoma. It remains a problem in and around Central Australia. Trachoma is this blinding eye infection that used to be called sandy blight. It disappeared from mainstream Australia 100 years ago. It's an unusual bacterial infection. It is spread from one child's eye to another. Children may have to be reinfected 150 times or so to end up with enough damage and scarring to cause blindness. The key to stopping these frequent episodes of infection is to keep all the children's faces clean. Working with government-supported screening and treatment programs, we have focused on improving facial cleanliness and hygiene. Our message is clean faces, strong eyes. And this is developed by MILPA, the Trachoma goanna. And MILPA is the name given by the Walkley people to our mascot, and it means the eye goanna. Again, a wide range of health promotion materials and approaches has been developed. These include posters, educational packages, TV and radio messages, music carnivals, large murals in many communities, and particularly football clinics run in conjunction with the Melbourne Football Club. Go the Mighty D's. We are working closely with other stakeholders on broader issues of hygiene, education and housing. And here I want to mention again the great support we've received from Rotary. The water trailers, the soap, the mirrors, the community washing facilities and so forth. They have made a great difference. To date, some real progress has been made in eliminating trachoma. The rate of trachoma in children in the endemic areas has fallen from 21% in 2008 down to 4% last year. There are still hotspot communities and there's more intensive work that's needed. We had hoped to have been able to meet the WHO criteria for the elimination of blinding trachoma as a public health problem by the end of 2020. But now much of this work has been put on hold because of the coronavirus. Of course, the COVID-19 pandemic is having a major impact on all of our work. If the coronavirus starts to spread in the Indigenous communities, it will have a very devastating impact and surely a very high death rate. So there's been a huge amount of work going on to support the communities and reduce the possibility of coronavirus infection. All the Aboriginal health services and their staff are fully focused on the COVID-19 programs, and other work is more or less on hold for the time being. Although you can wash your hands without washing your face, you cannot wash your face without washing your hands. This makes the clean faces, strong eyes message doubly important. And so, over the last month or two, we have been building on our trachoma messages to include the COVID-19 messages about hand washing, social distancing, sneezing into your elbow, and also helping with the provision of soap. Overall, for Indigenous eye health, our long-term goal is to establish equity by building equity for eye care, by building long-term and sustainable services. But this also requires ongoing monitoring and reporting. If it's not measured, it's not done, and it can't be managed. The Australian Institute of Health and Welfare now reports annually on the provision of Indigenous eye health services. So this is government data. This isn't a professor from an ivory tower in some university somewhere. However, to measure the real changes in eye health, surveys are needed to see what's actually happening on the ground. The National Eye Health Survey was conducted in 2015, and it showed that the gap for blindness had been halved from being 6 times higher in 2008 down to be 3 times higher in 2015. Although still not acceptable, some real progress was being made. We are waiting for a repeat survey that was due to start in 2020, that unfortunately is delayed by the COVID-19 pandemic. The Close the Gap Committee was formed the Close the Gap Committee was formed in 2008 by representatives of a number of the Aboriginal community-controlled organisations and interested non-government groups. They came up with some very concrete recommendations to literally close the 10-year gap in life expectancy and the other gaps in health, education and employment. The government's response was to move from the target or goal of closing the gap, of having the gap closed, to the process of closing the gap. The government reports each year on the progress or the lack of progress in implementing these changes. And it has taken more than 2 years to prepare a refresh for the closing of the gap process. However, in the last 6 months or so, there's been some dramatic change with broad community input. The National Coalition of Peak Aboriginal Organisations now has an equal role with governments in preparing the new approach. At last, it is being done with Aboriginal and Torres Strait Islander people, not to them. This is part of the interaction so urgently needed and so eloquently set out in the Uluru Statement from the Heart. Although much of our work has focused on eye care, there are some lessons that could guide others, providing specialist care for other conditions, such as diabetes, hearing loss or kidney disease. What we have really done is to strengthen primary care and to link them with specialist services. The recognition that there was not a simple fix of doing just 1 or 2 things was fundamental to our work. One had to look at the patient journey or the pathway of care and address each of the issues. This is where the health systems analogy of the leaky pipe was most helpful. We obviously had to work closely with community groups and organisations. It was also important for the sector to speak with one voice and bring together the community, service providers, and the professions. We had to focus on solutions, not just problems. The politicians and policy makers had more than enough problems. What they need is solutions. Finally, we had to focus on what needs to be done and not specifically how it be done in each particular clinic. This enabled many locally appropriate variations and initiatives to be worked through. Indigenous Australians still have unnecessary blindness and vision loss, but there has been some really good progress being made. We now have the elimination of Indigenous avoidable blindness by 2020 set out in the long-term National Health Plan that's been approved by the states and federal governments with strong sector endorsement. So we're looking forward with optimism in the future. I want to thank again Melbourne Rotary for the privilege of giving the 2020 Angus Mitchell Oration. I can only echo the words that Jean Harris, Paul Harris's widow, said of Angus Mitchell after he died. What a life of devotion and an inspiring example to follow. Clearly, Melbourne Rotary has continued his great work and is following his example. I thank you all for listening. Thank you.
Hugh, it's my great privilege to be able to express a vote of thanks from all Rotarians and guests who've had the privilege of hearing you speak today. It's been a very stimulating address and I think very appropriate for our 50th occasion since the Reverend Parsons started in 1971 with the first Oration. How to Fix a Leaky Pipe, I think, is a title which will appeal to all Rotarians who are very practical people, many of whom fix their own leaky pipes. We've learned a lot, I think, from the presentation today. From your statement that Indigenous people have 6 times 2.5 vision compared to 2020, which is particularly significant when you convert that back to a metric measure, Hugh. But it did serve to remind us that Indigenous children start off with eyesight and often finish up with the worst. And I think it's a credit to you that you've devoted so much of your life to trying to solve that problem and to provide equity in eye care as a long-term goal for Australians. Thank you for your leadership of Rotary's efforts to try and help in this situation through the Clean Faces and Strong program. You've acknowledged Rotary's efforts with water trailers, soap, washers. It's been a national program for Rotary, and it's been very much a focus of our club, the Rotary Club of Melbourne. And we're delighted that you're suggesting that we're on the road to good progress and that we're now achieving a 4% rate of trachoma amongst children. Finally, I think we all have been caused to stand back in the current COVID-19 pandemic situation, perhaps sobered by your comments and which have highlighted the vulnerability of Indigenous people at this time and the vulnerability of communities if COVID-19 gets a hold in Indigenous communities. This club and Rotary remains very committed to working with you and we wish you very best wishes with your future success in this project. So I'd now like to just ask all my fellow Rotarians and guests to join in hearty hand clapping from all the places in Australia and the world where we've been joining you. And thank you on behalf of us all. Thank you.
Very much, Peter. Thank you.
Thank you very much, Peter. Your words, superb as always, have left me to just convey again sincere thanks to our orator, Professor Hugh Taylor. The work that you're doing, Hugh, the work that Rotary is doing, the focus that we have on our Trachoma 2020 project is, of course, one of our centenary elevated projects, as we now are in true countdown for the 100th next year. So it's terrific to have the resonance of your address with our project in a timely way today as our 50th orator. And perhaps, as I said, there was a bit of commonality with grain between Sir Angus and our newest honorary member, Mev Connell. I think we need to explore the word Mitchell. Now I understand that Harold was your grandfather. There may be another connection, but that's
Harold was a benefactor, not my grandfather. The previous chair in ophthalmology is the Ringland Anderson Chair of Ophthalmology.
Well, there we are. But Mitchell's a resounding name.
Yes, indeed.
Congratulations to our newest honorary member, Mev Connell, and we do trust that you'll enjoy a celebratory nip this afternoon with Brenda, and we look forward to the occasion. Oh, he started now. We look forward to the occasion when we can have more than a nip with you, when we're able to be face to face again. I also am just amazed with the number of guests that have joined us, and as we've got a moment today, I had a chance to scroll through, and Joe Mavris gave me a few heads up that we've got District Governor Grant Hocking online, Philip Archer, Dale Hoy, some more luminaries from beyond our club, including Jesse Harmon and Mark Humphreys, and Murray Verso and Ian Knight. But I've got a couple of mates on board as well. Ian Armstrong from Nunawading is here today, as well as Mike Wetzler. But I did notice that Madhu is with us, our president of the E-Club, all the way from India. So I think Madhu, you get the prize today for the member who has joined us from the longest distance. I'd particularly like to thank the good work that's been done to ensure as many of our members are in fact able to connect with us. There's been an old iPad resurrected to be able to link in, and we're delighted that that member is now online, and there's been other arrangements made where members who weren't as savvy with computers are now on board and connected, and that's been a focus of rolling out these online deliveries, which sadly we may have to continue for a little while longer. I'm delighted to be able to now close the meeting, just reminding you that our next meeting is 6 o'clock next Wednesday night, so not at lunchtime, but in the evening, and the details will be in the bulletin. And so may I close by saying stay safe, and of course, share some kindness. See you next week. And we now have the national anthem so brilliantly played by Maestro David Cram.